Greetings from WSSCC Geneva. I am Archana Patkar from WSSCC, and I'm really excited to welcome you all to the first of our 2017 webinar series. This webinar today is on sanitation-related psychosocial stressors during routine sanitation practices among women. Before I introduce you to two of the authors of this seminal paper, I'd just like to go through a few housekeeping matters. The webinar will be for 1 hour, and we'll have about 25 minutes of presentation followed by discussion. So I really encourage all of you to activate your chat box on the lower left-hand corner, the small icon, and to write your questions as we go through the presentations or thoughts or matters for discussion in the chat box. My colleague Anthony here is taking notes, and we will try and pick as many questions as we can to put to our researchers for discussion. But we are aware in the limited time we have available that we might not be able to cover all of them. So we thought that we could segue this webinar into a more involved and longer community of practice discussion on the community of practice on sanitation and hygiene, perhaps a couple of weeks from now. So don't worry if we don't get to your question. We're taking note of all of them, and we really thank you for your participation and look forward to your active discussion. So with that, it's a real pleasure to introduce our two presenters today. Dr. Krishna Chandra Sahu, faculty at the Asian Institute of Public Health, Bhubaneswar, India, and one of the member of the research team who has done a lot of work on human rights and is also currently working on many linked issues that confront women and girls in their day-to-day quest for safe sanitation, including menstrual hygiene. Our second co-presenter is Dr. Kathleen O'Reilly, an associate professor in the Department of Geography, Texas A&M. Kathleen likes to introduce herself as a feminist researcher working on water sanitation and linked issues, and has worked for over 20 years and speaks fluent Hindi, I can attest to that, in urban and rural India on questions of gender, water governance, sanitation and development. So a quick introduction then to our webinar today and the paper that is being presented. Sanitation-related psychosocial stressors during routine sanitation practices among women. We all know that water and sanitation are fundamental rights to every person. These rights have basic requirements. Most importantly, the human rights parameters established. They must be adequate, accessible, safe, acceptable, and affordable for all without discrimination. Most importantly, the violation of these rights, of these parameters, constitutes a violation of women's rights, and I'd like to add human rights. Globally, about 2.5 billion people have inadequate access to improved sanitation, and 1 billion people practice open defecation. In India itself, about 300 million women and girls must defecate in the open every day. The biomedical impacts of poor sanitation access have received considerable attention. However, there remains limited understanding of the psychological and social impacts of inadequate sanitation for women and girls. This study examines sanitation-related psychosocial stressors during routine sanitation practices among adolescent girls, newly married, pregnant, and adult women at 3 distinct socio-geographic settings: urban, rural, and indigenous communities in Odisha, India. I now pass to Kathleen O'Reilly for the presentation. Over to you, Kathleen.
Here I am. Thank you, Archana. Greetings to everyone from Texas, where the sun has just come up. We often think of sanitation behaviors as urination and defecation only, but sanitation behaviors include menstrual hygiene management, like changing and disposing of menstrual cloths, and sanitation behaviors include associated personal hygiene, such as bathing or anal cleansing after defecation. Often sanitation behaviors require the changing of clothes, and nearly always require water. In this study, water availability was a key determinant of how, where, and the ease with which women could perform sanitation behaviors. And carrying water for washing was common in sanitation behavior. The sanitation environment can be bounded into three spheres: private, public, and open defecation sites. Private facilities were within the household compound, but not necessarily attached to the main dwelling, and they were shared by all family members. Lack of space to construct, landlessness, and cost can prohibit latrine building for some families. And once they're built, households may struggle to maintain their units in usable condition. Private latrines may go unused if they're damaged, for example, if the roof of the facility should collapse, or if they fail to offer adequate privacy, for example, if they should only have a curtain and not a door that could be firmly closed. Public facilities were usually erected by governments or non-governmental organizations to serve particular communities. And most of these were pay-per-use and can be prohibitively expensive. And there are difficulties, sometimes tremendous difficulties, with regard to maintenance, cleanliness, and a failure of safety or privacy features, such as doors that locked. Conditions of these public facilities can be extremely unhygienic if maintenance is not kept up with. In the morning, long queues can form, making for long waits for women, and the facilities are generally closed at night, a time at which they would be ideal. And access to water at public facilities is usually inconsistent. Open defecation sites can be found in both urban and rural areas where access to a latrine does not prevent open defecation. So open fields, vacant lots, roads, and railway tracks are all options for open defecation. Women went for open defecation when there were few people around, but they avoided going out at night or in the middle of the day when there was a chance that they would be completely isolated. All women experience one or several stressors related to the physical environment, social restrictions, or the threat of gender-based violence. In this conceptual framework, responses to environmental stress, social stress, and the threat of gender-based violence were experienced differently by, and we're looking here on the left side of the slide, in the green box, stage in the life course, whether an adolescent under the age of 25 but not married, newly married within the past 2 years, pregnant, or an adult woman, established woman who had been married for more than 2 years. In the red box, access to infrastructure, namely access to latrines and to water. And in the purple box, a woman's lived context, especially geography, whether that was an urban, a rural place, or an indigenous village, all three of which were covered in this study. And then, of course, cross-cutting inequalities such as caste and class dynamics within these geographies. The center blue box are the environmental stressors, social stressors, and threats of gender-based violence that women spoke of in interviews, and we'll discuss these in turn in just a few moments. On the far right, in the orange box, were some of the ways that women coped with these stressors by seeking social support, such as going in groups or being accompanied by a household member, as in the case of adolescent girls and their mothers, by changing their behaviors, going at a different time of day, choosing a different location on a daily or regular basis, and having to engage in incomplete behaviors, not being able to finish the act of defecation or to fully wash as she wished to. And then third, maladaptive behaviors, women regulating their bodies by eating or drinking less. And it is this constellation of context, stressors, and behavioral regulation that form this conceptual framework of women's experiences of sanitation-related psychosocial stress. And now I'll turn the presentation over to my colleague, Dr. Krishna Sahu. Thank you.
As Kathleen discussed, there are three types of sanitation stressors emerged from these studies. The first one is the environmental stressors, and how these stressors vary in different geographical sites. Let us discuss about barrier to access. When we discuss about the urban, the sanitation, the OD place especially is very close to their vicinity, but however, a significant man-made barrier to reach at the site. In rural, it's a long distance, and they face problem particularly during the cultivations and rainy seasons because of lack of space. And indigenous sites, there is a lot of empty space for OD. However, they always prefer the closed structures in order to avoid the wild animals. In relation to physical discomfort at site, particularly at urban sites, mud, stones, thrones as there, and very few options, which is always compounded by the high population density. And both at the rural and indigenous sites, rice stalks, mud, stones are the physical discomfort barrier. And at the rural side, more option available, and indigenous side, maximum options due to low population density. This slide says that, okay, population density in our globalization is the barrier to access the space. And all the sites, another issue, fear of supernatural, particularly at night, as emerged as one of the key environmental stressors. So in relation to social stressors, which are basically because of the cultural context. In urban slums, there are three types of social stressors, as Kathleen already discussed: privacy, social restrictions, social tensions. Privacy significantly lacking at the urban site due to limited space and high population density. And rural sites, it's lacking during the daytime, also in the indigenous tribal sites. In relation to social restriction, there is not much social restrictions at the urban slums for the women. But in rural setting, it is highly restrictive, especially for newly married women. She is not able to decide where to go defecations. It's always the decision is by other family members. So, and indigenous side, it's less restrictive, or restriction is not strictly observed. Social tensions, frequently quarrel happen in the urban sites where they do difficult, and if they choose other location or any office, empty space, or everywhere they face quarrel. And but in rural side, fewer tensions, but only it happen during the cultivations period if they choose other land. And indigenous community, it's very rare, but it sometimes occur because of the encountering with drunk man. So in relation to sexual stressors, we have three types of sexual stressors emerged from the studies. Peeping in the sense being watched, men being watched women when defecations or any sanitation activities. Revealing means showing the private part. Then rape and sexual assaults. Peeping all sides, particularly when women are alone or isolated. Revealing or flashing only mentioned in urban sites, and also rape and sexuals significantly differ by sites. In relation to rape and sexual assaults, almost all women from the urban slums experience, they share their experience or neighbors' experience, and this is mostly happen because of the overcrowding and encounter with strangers, and lack of social support and lack of privacy. In rural area, it's never mentioned with the context of interviews, probably because mostly it is underreporting, because they know each other, or because of the social structures. In village or rural community, they have good social structures. People never dare to commit this type of crimes. And indigenous community, it's rarely mentioned. And when it is mentioned, always within the context of encountering drunk men. When we see the setting-specific difference in experience of sanitation-related psychosocial stress, we found that in urban area, the physical environmental stressor is very high. It's because of lack of space and high population density. And the sexual stressor is very high. It's always because of the strangers and overcrowding. Then social stressor is very less, no restrictions. In rural sites, again the social stressor is high, and the sexual stressor is very low. Physical environmental stressor is moderate. And indigenous site, all type of stressors are moderate.
Next.
When you compare with the lifestyles among adolescent girl, newly married, pregnant women, and established adult women, the physical stressors was very high among the pregnant woman. It is obvious if one woman is pregnant and she will walk long distance for OD and she have to jump a high fence, or and she will be collect the water definitely, and all the other stressors was also high. And in relation to social stressors, the newly married woman is more restricted. Even the pregnant woman sometimes restricted if she is newly married. So the social stressors is high among the newly married woman, and the sexual stressors was high among the adolescent. And it's also linked with another issue, its reputations. If once something happened to the adolescent girl, the parents think and all think, will marry. She will lose the reputations. So the sexual stressors was high among the adolescents.
Okay, thank you, Dr. Sahu. That brings us really to some key questions. It's interesting to see the clear division between the range of stressors that we don't actually capture, either in our definition of success of sanitation and water schemes or hygiene behavior programs, but also the lack of recognition of coping strategies. So I'd like to just pose two questions to open the discussion, and also then take some of the questions that we've seen coming through. First of all, given that being human itself means that safe sanitation and hygiene facilities must be available as a basic everyday human and constitutional right, what can we do to integrate personal safety, dignity, and security into our wash services? Put simply, ODF is not enough, nor is hand washing, but really, how do we make absolutely sure that convenience, satisfaction, and comfort is experienced every time we need to accomplish or complete a sanitation and hygiene behavior? The second would be really about the next 15 years. How can achieving sanitation and hygiene safe and with dignity for women and girls, which is, of course, as we know, target 6.2 of the Sustainable Development Goals, how can this contribute to gender equality and empowerment for women and girls and for other excluded, marginalized individuals and groups if women still face a lack of privacy for their monthly call women menstruate, they must manage this menstrual blood every month. If they still experience inadequate access to safe and decent and comfortable water and sanitation. If the social restrictions on going out for defecation, despite the lack of absence of latrines at home, and more than social restrictions, the deeply embedded structural inequalities that make it unsafe for women and girls to answer nature's call. And last but not least, the extreme rape and sexual assault while women and girls attend to their need to defecate or manage their menstruation. With that, I think I'd like to pass over to our discussants. But I wonder, before I do that, if there are a couple of quick thoughts from our presenters before I take some of the questions. Over to you, Dr. Riley.
Yes, I'm here. Thank you, Archana. So some quick thoughts on the way forward. First and foremost, we want to know what women want. That seems rather obvious, and yet this kind of gender mainstreaming is absent in some approaches to sanitation provision. A focus on ODF is not necessarily giving women the kinds of units that will provide safety, dignity, and security. So we want to know what women want, and we want to do our best to provide that to them. There is a question of the daily in all of our study and in all sanitation questions. Because as we have seen, sanitation behaviors are vast, from urination and defecation to menstrual hygiene management to bathing. So looking to encompass that in the scope of sanitation programming is a key concern to addressing safety, dignity, and security for women. In terms of the second question about gender equality and empowerment, that's a laudable goal for sanitation interventions. I think in the long term, we want to be working toward the easing of social restrictions that cause women great stress. The presence of latrine facilities can do much for women's feelings of safety and their mobility in public presence, which is a key factor in social equality and women's empowerment. And then last, we can use this opportunity of sanitation discussion and provision to open up conversations about women's bodily processes, the naturalness of the need for urination, defecation, and menstrual hygiene management, and the accompanying hygiene practices, and do more to bring these things into public conversation and diminish the taboos associated with them. Thank you.
Thank you so much, Kathleen. I love the last one. Let's talk about it. Let's destroy the myths and taboos, and let's have pride in our bodies and recognize and respect difference. Over to you, Dr. Sahu.
As Dr. Kathleen addressed, gender mainstreaming is also a very important issue. Now we are in India, we are providing under the Swachh Bharat missions, we are constructing latrine. Even we are not thinking about the internal water sources. If we people will still struggle to get drinking water, why they will be use toilet? So in the construction of latrine and where we should think about the internal water sources. That was important. Again, also we are providing the structure, as sanitation is not include the defecations. It needs other activities. So when we are constructing that toilet or latrine, we should think also other part. That was very small, no bathroom and nothing is there. So we should also think about the structures and the other internal water sources and also the constructions.
Thank you very much, Dr. Sahu. Clearly, there is no conversation on equity that can divorce itself from technological issues and aspects or facilities design. So this is not whether we have more social science or whether we have more engineers, but it's a conversation that needs to bring together these different strands. With that, I'm going to move to some of the great sharing going on the chat box on my left. Many of you have shared, so I'm seeing from Ghana, from Nepal, from India, and also I see from different parts of Africa, the experiences from your different contexts and the stressors in play. One interesting question is whether women and girls, and this is from Ghana, who are, for example, traveling on a bus for a long distance, the bus driver stops, at some point along the way. It could be anywhere, in any of our contexts in Asia or Africa, and everybody gets down if they want to have a pee. Well, men can go standing up, as Isha Ray says in her paper, and points out that women cannot. They have to find cover and safety and dignity all in a couple of minutes before the bus driver sets off. His question is, given that they anticipate and know the setting, does this lead to less psychosocial stress, given that there are no surprises, more or less? Over to either Dr. Sahu or O'Reilly.
I don't think that anticipation of the situation would reduce women's psychosocial stress, because the lack of privacy remains. While a woman is able to stop the bus if she needs to urinate, then great, that's helpful. But the lack of privacy remains the same. So I don't see a reduction in social stress due to the knowledge of where it's going to happen.
Thank you. I'm going to add some of the questions, bring them together so that we can have a bigger discussion on the stressors. And, there are questions around, on the coping strategies as well. And we have some examples here about, reduced mobility. We have reduced intake. We have a specific question really on, this being a real issue, menstrual hygiene management in desert areas. This is from Bricks Arisar from Pakistan, where there is no water. So we see a range of contexts, environmental, and then you place on those, you juxtapose the social and sexual stressors, and you have a real daily nightmare. So specific questions that have come to us are, what are the very basic interventions that we can use to reduce psychosocial stressors for adolescent girls? Let's start with that.
In regard to your question about adolescent girls, we're talking about the home environment and the school environment. I noticed from your question that you're interested in both.
Yes.
We know that the provision of latrines in schools can be very helpful to girls if they are private, if they have doors that latch and that they remain unlocked, and if they have water access there. So in terms of the school environment, provision and once provided accessibility, including water for washing, has the potential to go a long way in terms of reducing girls' social stress around sanitation behaviors at school. Now, at home, the obvious answer is having a latrine at home. In places where that isn't possible, either the need to use a public facility or going for open defecation, two things come to mind. The first are the social restrictions on adolescent girls, particularly in India, with regard to the protection of their reputation. This kind of social restriction places tremendous stress on adolescent girls to be seen as pure and modest in public. So every venture outside the house for open defecation brings with it that stress. So moving toward a reduction in social restrictions of that kind is hugely important. The other is that a social support network at the household and community scale to protect, shall we say, and reduce girls' stress by keeping them in the company of those with whom they feel safe. So ideally, there would be provision of public latrines that would be well maintained and have low cost associated with them. But there's also this need for a social network that supports girls in their sanitation behaviors.
Thank you. So Josephine's question was partly answered by this. Her question was, what are the different stressors for adolescent girls in the home environment and in school? And are conditions improved in schools? I guess it's interesting if you kind of look at this question in the context of WASH and then look at it in the context of the day-to-day mobility for adolescent girls in many parts of the world. It's not that different. The coping mechanisms, the stressors continue whether or not they're answering nature's call. So I'm going to move to a specific question by Amrita Mathani from India. And what is the Ministry of Water and Sanitation doing to improve the situation? Is it doing anything in this regard, given that we have the huge Swachh Bharat mission, but we also have campaigns in specific states like Haryana, no loo, no bride? What do you think about these campaigns? Dr. Sahu?
So actually Swachh Bharat missions is more focusing on the construction of Latin and also behavioral change, how to use the Latin. But recently in Odisha, we constructed some Latin, but still there is a challenge in water. There is no internal water sources, and the fund they are providing also that is not sufficient to construct the latrine in a proper way. But another thing is all part of the SPM also. We are promoting school health program, and in school we are constructing the latrine with the adequate water sources, and also they are also providing sanitary pad for the menstrual management. This is in policy. Some places it's working, but often it is implementation is again a challenge.
Thank you, Dr. Sahu. I think, so there's a question also from Karan, I think from Kois Invest, if I'm not wrong. And he asks whether a proof of concept study will be available on reducing psychosocial stress in women by providing women's sanitation facilities. A WSSCC report on it, if he's not wrong, is anticipated. Let me nuance that slightly. I don't, from WSSCC, we don't believe that sanitation on its own can address gender inequalities, but we do believe that it's an incredibly powerful entry point for addressing a host of issues by unlocking safety and comfort and dignity in their day-to-day call, nature's call, and their monthly calls, menstrual hygiene management, all the taboo subjects. It enables women to have more voice, discover agency, and have more life choices, including the decisions they make whether or not to stay in school, to work, decent places of work, also unlock greater participation, and address a host of other rights. So no, I don't believe that we would have a study, but yes, we are financing a host of parallel interventions, research pieces, including looking at the impact of menstrual hygiene management, not just on reducing infections and safe health, but on voice and agency. With that, I'm going to move to another question here. This is specifically linked to health. In factories and schools where women and girls stop using toilets because of various reasons. This has ill effects on their health. Can you tell us a little more about how it affects their health? Who would like to take that?
Mostly we are constructing, providing the facility, but we know how this facility, because in this study also we found the public facilities that is not maintained properly. So probably that could be the challenge. They're not using that facilities.
All right, thank you.
Hello.
Yes, we heard that, but the question is really about the health-related impacts. What are the ill effects on their health? Would you like to expand on that?
Yeah, if the facility is not proper, for example, in public facilities, they are not frequently clean, and they urinate over and over, and there is no water. If they use that, definitely they have some problem related to urinary tract infections and other infections, and that might prohibit them to use. So, which is also emerged from these studies.
Thank you. Kathleen, did you want to add anything?
I would simply add that when we are considering public health, we are considering the whole package, and that's a really important piece of this study, which is that the physical and mental health need to be considered holistically.
Thank you. I certainly, on a personal level, have the reason I use the word seminal, I don't use it lightly, is because this has certainly impacted my way of working. If we look at the sector, what we're really missing is the day-to-day, the daily stressor. Every time I wake up, if I have to think of finding a safe place before I can defecate, I'm frightened of snakes or worse predators of the humankind, how am I really starting my day? This is something really quite basic that we've ignored in the sector. So I find it even more important than the risk of infections, etc., which have been studied and for which there are preventive measures in place. We clearly need quite urgently a revolution to make sure this is not happening. I'm just going to go to the next question, which is whether your study evaluated the synergy between different projects and how this helped address these stressors. Well, if it identified them, I would add, in the first place. I find that in some cases in my country, not all of these aspects are discussed here and are addressed differently by different partners. How can the sector approach to programming WASH help to ensure that across the board we address these issues systematically? And this is from Matthew.
Yeah, actually, in these studies, we have other follow-up studies also. So we initially we thought that nobody think about the sanitation-related psychosocial stress. So this paper emerged, and we have also subsequent another paper also that SDC relating structured data collections. Then we follow to this. We have also quantitative studies, which is we are working on this. So yeah, definitely the problem, magnitude of the problem or dimension of the problem vary from place to place. But for example, when you think about urban sanitation policy, then you think different way than rural or tribal.
Thank you.
Maybe Kathleen will add something to this.
Kathleen?
Yes, I'd be happy to. We want to open up the conversation at multiple scales of government and governance. So far, we've really kept the focus of this conversation about programming at the local level, but I'm sure the participants are thinking beyond that. And when I was speaking earlier about opening up discussion and the breaking of taboos, part of the sector approach is to broaden its scope and to bring in all levels of government and government officials and programming officials into the conversation about this combined impact of physical and psychosocial stress on women's health. There's a responsibility that needs to be spread throughout social structures, both within communities more locally, but also across government agencies.
Thank you. And this links to a couple of questions that have come through that the sector has invested quite a lot in. The need for more education and awareness raising. But let's look back over the last 20 years. Our education and awareness raising has focused on cutting the fecal chain, spreading hygiene behavior awareness, and really looking at contamination, pollution, etc. But has it really looked at basic human rights and guarantees and accountability? So shouldn't we also be looking a little bit more at accountability mechanisms and the role of communities, but also duty bearers, families, individuals, in ensuring dignity, safety, convenience, and comfort are a part of the water sanitation hygiene package? And that, since that was a reflection, and I do want to take as many questions as I can, I'm just going to read out a thought here. I noticed that the marital status of women is a key issue. What changes occur when women have been, what changes when women have been married for a while? Are there less restrictions? Are these connected to childbirth? Are there no large populations of single women in the chosen sample? That's a specific one. So over to the researchers.
Yes. So marital status of women is a key issue as it relates to social restrictions. So in the Indian context, for women who are newly married, they face the greatest social restrictions on their behaviors and mobilities. Families want to be clear to the rest of the community that they have married into a good family with a good daughter-in-law. Women also who are newly married are at the lowest rank of the family hierarchy. So in time, those restrictions begin to ease as the woman is more integrated into the family and into the community, and her reputation is established. But what also helps a lot is the birth of a son. And with this, a woman moves into, we might say, established womanhood, established adulthood, both within her family and within the community. And as such, she does experience less restrictions regarding her public mobility and her ability to make demands on the family, which might include the building of a latrine facility at home. In the context of this study, there were not large populations of single women. I believe that's correct. Isn't it, Dr. Sahu?
Dr. Sahu?
Hello?
Yes.
Yeah, I think some connection problem.
Okay, I'm going to have to move on. So I'm just sharing also, as you've seen, many of you will have seen Colin's comment that he had a slightly different finding in Ghana. We'd be very interested in seeing your study, if you could share it with us, where rather than psychosocial stress, they reported discomfort around paying for services, and also poor cleanliness. But despite being aware of health implications, they did not really ask so much for a change. With that, I'm moving to Ala Baksarisar, where he also shares that gypsy and nomadic communities in Pakistan do not have latrines at home and no water connections. So they defecate in the open and wait until sunset, and no really awareness sessions for girls on menarche or menstrual hygiene management. I think the experiences that we're seeing here shared And we have more from Daniel, defecation and urination in a bucket. And we have Nathalie as well, but that's coming to really the contributions from government. So I'll just stop here before we go on to the next few. What we're seeing is a range of ad hoc, context-specific coping mechanisms that women and girls adopt every day in order to respond to their the lack of adequate human-friendly facilities. This may change by context, but the principles remain the same. And I'm really grateful to Kathleen for pointing out the change in status that makes it safer for a woman who has given birth to a son suddenly to be able to use the same inadequate facilities. This points to, we really need to look at the complex overlay of stratifiers around inequality that play out not just in water sanitation, but across education, health, and the world of work as well. This deeply rooted gender inequality plays itself out more significantly with water and sanitation because of the very nature of its daily need. We must defecate, wash ourselves every day, and that's what makes it absolutely unacceptable that half the world's population may have to think twice before they can answer this call. We have a couple of more specific thoughts. We only have 5 minutes left, is that right? 3 minutes left. So what I'm seeing here is that we also have experiences from Francophone Africa, where we are seeing some of the interventions and responses towards psychosocial stress and menstrual hygiene management, where when toilets are gender adapted and women friendly for MHM, it really reduces the number of hours and the kind of lost hours that women have to spend during their menstruation if they are women friendly and adapted for menstrual hygiene management. But it's true. We've had 3 questions, I think, on the evidence. We do not have systematic evidence to show the positive impact of MHM, given that we're, well, I won't say at 0.0, but maybe +1 in this trajectory. But as we look at the life course, I think what the study is telling us to do is to look at the differences, biological, between men and women, their needs, and to really address these systematically as we go about 6.2, but also more broadly 6 and the other goals. I think what's important is to really check whether we could continue this discussion through the community of practice on sanitation and hygiene so that many more people can share, I think, in these 2 areas. One, the different stressors that are faced in different geographies and contexts. I think it would be wonderful to have these from different contexts and then bring out the common strands. And secondly, look at the coping mechanisms, but most importantly, 3 of you asked, what can duty bearers do and we in practitioners also do to address these stressors? So I'm going to go back now for a final 1-minute comment from our 2 co-presenters. Over to you, Kathleen.
Thank you. In my closing remarks, I want to stress, as Archana has done, that what we're talking about are daily experiences of women and girls, and that these physical and psychosocial stressors have long-term cumulative impacts. So there's a great deal of urgency that needs to be felt here on remedying the situation. Now, we are working in contexts where a variety of sanitation programming is going on, but is not necessarily giving attention to this combined physical and mental stress that women are facing. I'd like to see women's concerns placed at the forefront of sanitation interventions ahead of the building of latrines. We are speaking of a large sector of the population undergoing daily stress regarding an everyday bodily function. Latrine building is fantastic. I want to see more of that. I want to see water access that enables all populations to be able to use facilities. But the question of women's ability to use these facilities safely and regularly is a key concern, and one that has to be at the leading edge of sanitation programming.
Thank you, Kathleen. Dr. Sahu?
Thank you, Kathleen, and thank you, Archana, for this wonderful thought and organizations. And we have also very interesting questions. We are not able to answer all, but it provides a very nice idea for future. And my last comment is, when you are thinking about any sanitation policy, the involvement of women is very important. Because in one of my studies, we are going to soon publish that one, in gender disparity in sanitations. Even the male never think that they have the responsibility of household sanitation activities. So some setting, particularly India, Bangladesh, and Pakistan, we should also more gender involvement and gender related policy is essential in order to change this practice and change the behavior. Otherwise, policy alone will be not work if the community will not support.
Thank you so much, Dr. Sahu. That's exactly what women across 8 countries last year told us through 51 consultations. Listen to us, work with us, do not act without us. So with that, I'd like to thank the 50 participants on this webinar, our co-presenters, Dr. O'Reilly and Dr. Sahu, their co-authors, Christina Holland, Bethany Caruso, Babani Das, Matthew Freeman, Pinaki Panigrahi, Rosalind Swain, Robert Drybabus, and my colleagues at WSSCC. Thank you very much.
Thank you.
Thank you very much.